If you are over the age of 60 and you take a daily low-dose aspirin, listen carefully. A seismic shift in medical guidelines has told millions of older adults they should stop taking this pill, mainly due to the risk of serious bleeding. You have probably heard this new warning from your doctor or seen it in the news from the USPSTF and ACC/AHA. And you are right to be concerned about the bleeding risk, but there is a far more immediate and potentially fatal danger that almost no one is talking about. It is the unseen threat that surfaces the moment you decide to go cold turkey. The silent killer isn't the aspirin you take today, but the abrupt cessation of the aspirin you took for years. In the next few minutes, I will show you the fatal error most people make when stopping their daily aspirin. I will reveal the terrifying thrombotic rebound phenomenon that can make your risk of a stroke or heart attack surge by up to 3 times in the first month. More importantly, I will give you the 3-part taper and bridge strategy, the precise clinical discussion you need to have with your physician to ensure you step away from this medication safely. This is not a message of fear, it is a critical warning to empower you with the truth. Stay with me, because what you learn in the next few minutes could genuinely save your life, or the life of someone you care for. The fatal rebound phenomenon. For decades, aspirin was hailed as a miracle drug for primary prevention. It was the health insurance policy you took every morning against a heart attack or stroke. But the science is now clear. For many older adults without a prior cardiovascular event, the risk of gastrointestinal or intracranial bleeding often outweighs the benefit. So, the decision to stop is medically sound. The flaw is in the method of stopping. When you suddenly discontinue a long-term aspirin regimen, you are setting the stage for what physicians call the platelet rebound phenomenon. To understand this, we must first understand how aspirin works. Low-dose aspirin works by permanently disabling an enzyme called COX-1 in your platelets. This action is crucial because it stops platelets from clumping together to form a clot. A platelet's lifespan is about 7 to 10 days. When you take aspirin daily, you effectively inhibit the clotting ability of your circulating platelet pool. But here is the critical part, the part that creates the danger. When you suddenly stop taking the pill, your bone marrow immediately begins to produce a surge of brand new, completely uninhibited platelets. These new platelets are fresh, fully active, and some studies suggest they may even be hyperactive. They flood your system to replace the old disabled platelets. This process essentially creates a transient state of hypercoagulability. It's an aggressive, biological overcompensation. The scientific evidence is striking. A meta-analysis of studies looking at patients who suddenly discontinued low-dose aspirin for various reasons showed a significant spike in risk. For those who stopped abruptly, the risk of non-fatal myocardial infarction, a heart attack, or death from coronary heart disease surged by up to 3 times compared to those who continued their therapy. This risk is not theoretical, it is clinically documented. And the danger window is not indefinite, it concentrates in the period immediately following cessation, specifically the first 4 to 12 weeks. If you stop aspirin cold turkey, you are unknowingly entering a high-risk zone for the next 90 days. This is why the phrase, "just stop taking it," is not only incomplete advice, it is dangerously misleading. The strategy cannot be just about quitting a medication. It must be about safely replacing its crucial function. The clinically discussed tapering strategy. The foundational rule for every patient, regardless of their history, is this: never stop aspirin without a direct discussion with your doctor. This is especially true if you're on aspirin for secondary prevention, meaning you have already had a heart attack, stroke, or stent placed. For you, the rebound risk is exponentially higher, and stopping should only be done if you're facing severe, imminent bleeding. For the primary prevention group, those without a history of an event, the medical goal is de-prescribing, but safely. Since there is no single globally standardized tapering protocol for low-dose aspirin, clinical strategy focuses on a taper and bridge approach. The purpose of a taper is to gradually allow the body to normalize platelet production without the sudden, aggressive surge of hyperactive platelets. One common strategy discussed among clinicians is reducing the frequency rather than the dose itself. Instead of taking 81 milligrams daily, your doctor may guide you to a schedule of every other day for a designated period. This technique is designed to act as a bridge. It means that while your body transitions, you maintain some level of platelet inhibition to mitigate the sudden shock to your system. But even this needs to be individualized, because ultimately, the decision to stop aspirin safely rests on knowing your underlying risk factors. The risk-benefit calculation for older adults is intensely personal. This is why the most valuable step you can take today is preparing for this discussion with objective data. You need to know two crucial numbers: your personalized bleeding risk score and your genetic risk profile. Physicians use established tools like the HAS-BLED or ABC bleeding risk score to quantify your likelihood of a major hemorrhage. A high bleeding score means the medication is probably doing more harm than good, and stopping is critical. But equally important is knowing the severity of your underlying cardiovascular risk, particularly your lipoprotein A levels. Lipoprotein A, or LPA, is a powerful, genetically determined cardiovascular risk factor that aspirin cannot effectively treat. If your LPA levels are significantly elevated, stopping aspirin might leave you completely unprotected against a powerful genetic foe. This is a hidden danger that requires a simple blood test. Understanding your LPA level is the final piece of the puzzle, the ultimate decider in your low-dose aspirin journey. If you want to know more about this critical blood test and why it is the key to safe aspirin cessation, I have covered it in detail in our next video. You can find the link in the description or wait until the end of this video for the direct recommendation. But first, we must discuss the bridge, because once you taper off aspirin, you cannot just leave your blood defenseless. The 3 natural bridges to anti-thrombotic safety. The goal of this section is not to replace medicine with supplements. It is to replace the function of antiplatelet therapy with scientifically supported natural modulators, the bridge you can use during and after the tapering process to keep your cardiovascular system safer. The 3 natural strategies I recommend are backed by substantial research into blood viscosity and vascular health. 1. The fibrin-dissolving enzyme, Nattokinase. Nattokinase, or NK, is an enzyme derived from natto, a traditional Japanese fermented soybean food. This enzyme is a potent fibrinolytic agent, meaning it directly dissolves fibrin, the protein that forms the mesh of a blood clot. Research has shown nattokinase improves blood flow by inhibiting platelet aggregation and directly degrading fibrin, similar to the body's own plasmin enzyme. It is a powerful tool to manage blood viscosity and prevent the formation of new clots, acting as an excellent functional replacement for the blood thinning property of aspirin. The advantage here is that nattokinase, when used correctly, does not carry the same systemic bleeding risk as aspirin, making it an ideal candidate for your bridge strategy. The clinical consensus suggests a dose around 2,000 fibrinolytic units, or FU per day, but higher doses have shown promise in managing atherosclerosis. As always, consult your physician before combining nattokinase with any antiplatelet or anticoagulant drugs. 2. Therapeutic omega-3s, EPA-DHA. Many people take fish oil, but few take it in the correct therapeutic amount to replace the anti-inflammatory function of aspirin. This is not about general well-being. It is about anti-thrombotic support. Omega-3 fatty acids, specifically EPA, reduce chronic systemic inflammation. Chronic inflammation is the root cause of plaque rupture and clot formation, which leads to heart attacks and strokes. By calming this inflammation, you are addressing the fundamental mechanism that aspirin was only partially managing. You need a high-quality, high-potency formula, rich in EPA, not just the low-dose maintenance supplement often sold over the counter. The therapeutic dose for cardiovascular protection often falls between 2 and 4 grams of combined EPA and DHA per day. Make sure the supplement is in the highly bioavailable triglyceride form for maximum efficacy. 3. High-activation curcumin. Curcumin, the active compound in turmeric, is one of nature's most powerful anti-inflammatory agents. While aspirin directly targets platelets, curcumin works upstream by dampening the entire inflammatory cascade that activates those platelets in the first place. It is a critical component of the bridge strategy because it addresses the underlying environment of the blood vessel walls. By reducing oxidative stress and inflammation, curcumin indirectly helps keep platelets calm and less prone to hyperaggregation. The key to its effectiveness is absorption. Standard turmeric powder is poorly absorbed. To make it effective, you must use a highly bioavailable formulation, such as a liposomal product or one that includes piperine, a compound from black pepper, which has been shown to dramatically increase curcumin's absorption into the bloodstream. This trinity of nattokinase, high-dose omega-3s, and activated curcumin provides a robust, multi-layered support system. It is the intelligent bridge you need to cross safely from a long-term drug dependency to a state of natural, optimized cardiovascular resilience. Conclusion: take control of your heart health. We have covered crucial, potentially life-saving information today. The key takeaway is that the biggest risk of low-dose aspirin for older adults isn't just taking it, it is the potentially fatal rebound effect that happens when you stop it abruptly. Your strategy must include 3 steps. 1. Consult your physician and quantify your risk using the bleeding score and lipoprotein A test. 2. Follow a medically guided tapering strategy to safely reduce the dosage frequency. 3. Implement the 3 natural bridges: nattokinase, therapeutic omega-3s, and activated curcumin to manage blood viscosity during this critical transition period. This is how you take back control of your health with confidence and scientific backing. Now, I want to hear from you. What is the longest period you have been taking aspirin, and what is your biggest fear about stopping it now? Share your experience in the comments below, and let us build a community of safe, evidence-based aging. And as I mentioned, knowing your lipoprotein A level is the ultimate decider in this process. You must watch my next video where I break down exactly what that LPA test is, how it works, and why it is the low-cost blood work that determines your true heart risk. Click the link on your screen now to watch the low-cost blood test that tells you if you need aspirin. Thank you for watching. Medical disclaimer: the content presented here is for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified health provider with any questions you may have regarding a medical condition or before making any changes to your medication regimen or diet.